Good morning, good evening, good afternoon. This year, I have a special announcement as the president of the ISRS. We have multiple sources of information for refractive surgery, including the JRS, and we have a special code ESRS 2020. So please consider visiting us at our website and learning more about the society and eventually being part of our family. It's an honor to participate in this webinar on the talk related to artificial intelligence for biomechanics and tomography. These are my disclosures, including, of course, Oculus, with who I had the privilege to collaborate with over the last more than 15 years now. And of course, I want to mention my collaboration with the BRAIN, the Brazilian Artificial Intelligence Networking in Medicine, which is completing 10 years. So Oculus is completing 125 years, and the BRAIN is now completing 10 years. So it's a very special year for all of us. And I have to acknowledge my collaborators in Brazil and Portugal so that I can present all this work. It's very important that we try to make things easier. We are overwhelmed by technology, by information, and this overwhelming, we have to think about ways of making life simpler, but not in a simploric way. So it's very important that we go to the artificial intelligence understanding. It's a true revolution in evolution, and artificial intelligence should be understood as a branch of computer science in which we can recognize patterns, make predictions. We have supervised learning and unsupervised learning. Supervised learning is when you have label for the data, and supervised learning, you don't have the label data, but the machine learning processes will find clusters, will find patterns, and try to make some predictions about the data. The reinforced learning is very important. I will discuss very much about it today because it's our ability to keep ourselves getting better and better. I think it's very much in conjunction and relational to what we are doing in this planet to evolve. Machine learning has a special part, which is deep learning. Deep learning allows us to go deeper into the source of the data and go beyond not over the data that we have available, the parameters. So we can create new parameters, and deep learning is probably the next move that we are going to use for really improving the ability to get the data and make clinical decisions. I like this philosophy in which we have to understand ourselves and understand what we are trying to achieve, the enemies. So what are the goals on diagnostics for keratoconus and ectasia? We want early diagnostics, we want screening, we want prognosis. We just heard Michael Bevin's great, brilliant talk on the follow-up, which is important, but we want to stage to see the severity of the disease. Patient education is going to be very important. And of course, Michael just mentioned the point on the bureaucracy for medical treatments. You need to have documentation, and individualized treatments will come from these technologies. We have the multimodal imaging, since topography, shine-field tomography, biometry, ocular wavefront. We have all this data along with corneal biomechanics to complete what we say as multimodal corneal imaging. Multimodal corneal imaging is going beyond but not over. Beyond but not over the detection of keratoconus for the enhanced ability to characterize ectasia susceptibility, which is different when you do therapeutic procedures in patients with true keratoconus and ectatic diseases. We broke the paradigm, so we have to understand that the screening for ectasia susceptibility is different than diagnosing ectasia and eventually staging the disease and doing the follow-up. But these are the whys that we need the data. Basic concepts for screening are very important. We have data acquisition and then parameters. Michael made a beautiful point on his display that look at the precision. The precision is the repeatability of the parameters, the standard deviation of multiple measurements done in the same subject, which is different than the accuracy, which is the correctness of the data considering a reference value. This data will be presented in clinical displays, and artificial intelligence is very powerful to enhance the ability of this clinical data for making good decisions so that we can help the patients the best way as possible, which is, by the end of the day, always the goal that we should have in our mind. The Pentacam, for example, which is now a multimodal imaging with axial length and ocular wavefront with the new tools available in the market, would give you a lot of information with other situations like angle closure glaucoma, not only keratoconus, but when you see angle chamber angle, AC depth, AC volume, you have different situations and you can see how the patient is sitting so that you can really screen for the disease. The Bell and Ambrósio, which is now over, I would say, 12 years, we have the deviation from normality that combines front and back surface enhanced elevation and thickness profile. Michael just made a brilliant talk, and the precision here is the threshold if you see that this patient has or not a statistically significant change in the front-back surfaces or thickness mapping. When we think about ectasia, I always consider this 1998 publications. These publications lead to the pathophysiology of ectasia, high myopia patients treated by LASIK in which biomechanical impact caused ectasia to progress, and a patient with a formed fruste keratoconus, which is a misleading term, I agree. But formed fruste keratoconus here is a relatively abnormal cornea characterized here by the front surface curvature map with an asymmetric bow tie. The pathophysiology of ectasia, though, is related to innate biomechanical properties and the impact from the environment. Actually, any disease in medicine can be looked at this scenario, and eye rubbing along with laser vision correction procedures will be very important. A very major point is that any cornea may develop ectasia, considering the impact and the resistance. A very nice series of cases with over 300,000 LASIK procedures was demonstrated by Steve Schallhorn, in which you can get cases with a normal topography and even tomography in the ectasia cases, actually 30% of these cases, and also cases with a pre-op abnormal topography and tomography, it would be 1% of the stable no ectasia cases. So what is formed fruste keratoconus? Formed fruste keratoconus is a complex term, and when we think about the question, is topography enough? Yaro Rabinovich would say yes, topography is enough because in cases like this, which he calls formed fruste keratoconus, because there is abnormal topography, typical keratoconic topography, in a patient with a normal slit lamp and normal distance correct vision. Steve Kleiss would say that the fellow eye of this patient will be a formed fruste keratoconus, and sometimes he uses the term unilateral, which is sometimes misleading. My opinion is that all these cases, they are asymmetric ectasia, and I can even claim that this is not an opinion, this is a fact. And we need to go beyond, not over the front surface here, so that we can see if there is an abnormality in this eye, so that we can demonstrate if this is a formed fruste eye, or susceptible eye, as I prefer, or if this is a true unilateral ectasia due to environmental problem. So the mild keratoconus is a very nice term by Jay Krashmer in a brilliant talk from the Cornea Sub Day at the Academy a few years ago. But I would say that there is no consensus. And my humble contribution is that ectasia susceptibility will be a better term to define formed fruste keratoconus. And formed fruste keratoconus is definitely not. It's a concept of a clinical situation in which the disease is present, but in a very, very mild with a subclinical, subsymptomatic situation. It's not a topometric classification. In situations like this one, in which the patient had LASIK with a thin flap and PTA of 0.36, a little bit of a yellow in this 1.5 scale from Smolik and Kleiss, a lot of people would say, now that I know that there is ectasia after LASIK, this is a pathognomonic of formed fruste keratoconus. We looked at the variability of subjective classifications from corneal topography maps, first sending this 1.5 scale and then sending the 0.5 normative scale, which is called the Holiday scale in the Oculus Pentacam and Keratograph. We asked the colleagues, 11 colleagues, classified based on the criteria from Brad Rundeman, 0, 1, 3, and 4. Interestingly, the first scale with the classifications vary from 0 to 3 with a mode of 0. The second classification, they had a 0 to 4, but still a mode of 0. So the variability is very important. This data was available, but we didn't have the Pentacam Belli and Ambrósio at that time. But we can use the raw data, the U12 files, and calculate retrospectively. And the D was 2.46, much higher than 1.5, which is the threshold I would recommend. The Artmax is another index that here would say that this patient has ectasia susceptibility. I don't think it's a keratoconus, but ectasia susceptibility. When we look at the enhanced ectasia study, in which we had precious data from 105 pre-op ectasia cases and stable cases, we had a pre-op from 3,278 cases, you see the IS value, the inferior superior asymmetry index, which some people call Habilowitz, will be very specific. In fact, 98% specific, consider 1.45. This is important because people are obeying. They are looking at topographies, but it's not sensitive. It only detects 22.9%. The bad D, which was not available when this surgery was operated, would be much better. Will go to 59%. However, the specificity is a little lower. Interestingly, we have to understand the objective parameters, the populations, and Bernardo Lopes, in his brilliant thesis, he looked at the data on patients that had normal topography from the fellow eyes of asymmetric cases, and also this pre-op, 60 of this pre-op that we had available that time. We use artificial intelligence, and then we get the Pentacam random forest index, which would detect 74.3%, but you still have cases here. So it's going beyond but not over, into the biological properties. And corneal biomechanics is now available with the Corvis. The Corvis is ultra high speed shine through camera, which takes in 31 milliseconds 140 frames. And these frames, you can see a very abnormal cornea with a mild keratoconus and a very thick cornea with an ocular hypertension, which is kind of the opposite of a weak cornea. And you can have deformation amplitude, velocity, and all these terms that can be combined into the corneal biomechanical index from the Corvis. And this is the work that has been done in conjunction with Paolo Vinciquerra. I would just show a patient that came to me this week. This patient was asked me to see as a second opinion for doing a Athens protocol, cross-linking plus PRK for ectasia, late ectasia after PRK. And you can see the front surface data. It's very abnormal. Interestingly, the tomography data, you have a thin cornea, but with not a normal posterior elevation. The CBI post-LVC is 0. So it's pretty much important to understand this patient has haze and definitely doesn't need cross-linking. It can be an ultra-thin cornea after a PTK to improve that. Our ability to look at tomography and biomechanics goes into the domain of the TBI. This is the JRS Integrated Shine Fluid Tomography and Biomechanics paper that we published in 2017. And we looked at 94 cases with a normal topography based on objective criteria, and we had a sensitivity of 90.4%. Actually, it was virtually perfect for the clinical ectasia cases considering the normal eyes. The epitomize of ectasia susceptibility is what believe we are trying to achieve here. And interestingly, the random forest was the best with before and out cross-validation. So we have cases like this one. This is 27 years old that comes eventually with a 2015 distance corrected vision and eventually good candidate for laser vision correction. If you just think about front surface, good vision, relatively good age, thickness, but look at the posterior flow. There's a little bit of yellow here. Is this patient abnormal? When we go to the TBI, this is a 0.41. This is a relatively susceptible cornea. You see the stiffness parameter is in the red range, the ART8. This is a patient that has a fellow eye with a mild clinical keratoconus. So this patient is a good example in which you enhance the sensitivity for detecting high susceptibility for ectasia, which you can call form fruste or not, but this patient has abnormal cornea in the right eye. This is a very similar situation from the case that we first published in 2010. That's when I coined the term ectasia susceptibility. This patient is still stable. If you look of the tomography data, you have a borderline bad D, 1.37, 0.19 of the PRFI. This patient may qualify for LASIK. But if you see the tomographic and biomechanical integration of 0.78, this is a very abnormal weak cornea. The patient has 20/20 plus now this is correct vision, and this patient does not have keratoconus. She has ectasia susceptibility. Very much of interest is the son of the patient that has this is correct vision of 20/20 and a little bit of a possible in the TKC, a little asymmetric both eye. But this is the patient that we have to really tell them not to rub the eye and follow up. I don't think cross-linking is indicated now, but definitely the Bellin ABCD should be taken care in 6 months from this measurement, and this patient thankfully is still stable. Both eyes can occur with a bilateral form fruste, and this is the best example of that. This is an identical twin sister, and all the measurements in one of the sisters were normal in the front surface. Here is the placido disc and the Scheimpflug topometric display, but the TBI is abnormal. And this is a very asymmetric ectasia, which is, by the way, interestingly, a very interesting point. This is one of the patients that I have learned more in my career. The patient had high myopia presented for laser vision correction. We decided the enhanced elevation was normal, 1.27 in the right eye and 1.07 of the D in the left eye. Arcmax was a little low, but we decided to go for a SMILE. SMILE is a procedure that I found myself very much in agreement with the benefits of SMILE because we have less biomechanical impact, but you still have a weakening because you're removing tissue and you're weakening the cornea. And also you have lower dry eye indices. You still impact the ocular surface. But this time it was 2014 when I started doing it. I was just finishing my learning curve, and you see how smooth it is using Dan Reinstein's technique. You identify the front surface and then the posterior surface of the lenticle. And then these patients, they do very well. These patients did really well. In the first week, she got 20/20 plus in each eye, gaining vision, better than this is correct vision. She was very well in the first year and second year. She did not come back in 2017, but when she comes in 2018, she was complaining with decreased vision in the right eye. 2000 corrected to 2025 with a -4 of cylinder. This was a patient that I was really unhappy to see that she developed ectasia. The left eye was still relatively stable, and you can see here that in 2016 with 2025 plus, if I would be careful to look back at the posterior elevation, I would have been able to detect the abnormality. This patient has ectasia, no question. The left eye epithelial thickness is very handy for that. Patient was advised not to rub the eye, and the treatment was properly done with a corneal ring along with a transepithelial cross-linking, and she did very well. But what I have learned from this case, we had the data from the pre-op, and the TBI was 0.72 in this patient in the right eye and 0.25. So she was a susceptible cornea, and if I had that data, I probably have prevented this case. So we go from SMILE to frown, but back to SMILE again. But the interesting thing is not everything is a SMILE. We have to keep ourselves moving. We have to keep ourselves moving and evolving. Some reports of lower accuracy, even though the TBI is the best parameter, if you compare with any other parameter, the TBI is not perfect, and we acknowledge that, and the sensitivity can get better. So these reports lead us to the need for the optimization of the TBI, now with a higher number of normal topography cases, and these cases allowed us to do more training and more testing and machine learning algorithms to improve it. So here is a summary of this work that has been very nicely done by Gileuza Leão from the brain, in which we improve the sensitivity even for the clinical ectasia cases. You have some normal cases now up here, which I believe these are the cases that are really susceptible. But from 75 to 85% plus, you improve the ability to detect the normal topography eyes. Some cases down here are truly the cases that are related to the unilateral ectasia. And you see an enhancing of sensitivity without losing sensitivity comparing to the classic version 1 TBI. This will be the very good example of unilateral ectasia. The patient did well with a corneal ring in the right eye and very stable in the left eye. He moved to London, and everything that could be done in his eye was measured. Everything normal, including epithelial thickness and the alongside and the Myanga Canal score available on the Orbiscan. He comes back for a follow-up in 2018, and he was still normal and stable in the left eye. So this is a very unilateral ectasia, which is in agreement with the consensus that Michael just pointed out. True unilateral keratoconus does not exist, but ectasia can occur secondarily to a purely mechanical process, and it can be unilateral. When we consider the paradox of AI, is that AI is very important for ourselves today. We have AI in our smartphones. We have AI everywhere in our lives. Individualized medicine will benefit from AI, but we still need to have humanized medicine, and patient education is a must. The medical mission to heal few times, to relieve often, to comfort always is in agreement with our campaign, the Violet June. And one of the messages of the Violet June is that eye rubbing or scratching the eyes aggravates keratoconus and may even cause ectasia. This is not the same thing, and appreciating the difference is a huge step forward for understanding corneal ectasia and keratoconus. So screening for ectasia is multimodal. We need artificial intelligence. And this is a very nice summary from the patients that have low susceptibility, in this case may have even microkeratome LASIK. Some of the cases will benefit from PRK or trans-PRK and SMILE. And then if you go to the yellow to orange, you're probably going to go for a fake IOL. If you go to the red, maybe you are a therapeutic procedure which has to be differentiated. Another aspect that I didn't mention is the relational tissue alter. This is the impact from the procedure that we can use artificial intelligence to measure, considering the data that we have. And of course, consider doing all the best for helping the patient. Thank you very much for your kind attention.
Thank you very much, Professor Ambrósio. As always, a very informative talk. So we're going to go to some questions now. I think questions that's quite often asked in general, is the TBI an average of the CBI and the BAD final D?
Well, thank you very much for this question. And this is definitely one of the most important concepts. The TBI is an advanced AI with random forest. TBI is not the average of CBI and BAD-D. What we are doing is much better consideration of artificial intelligence for the data analysis. So we have more data and much better analysis. It's just a huge step forward in terms of ectasia screening. The CBI has its own value along with the BAD-D, but they are linear regression analysis. So they are much different than the TBI. That's why you have cases that you have a higher CBI and a lower TBI and vice versa with the BAD-D as well. Thank you for this question.
Thank you. And then there is a question for Professor Bellin that just came in as well. Is the ABCD progression display, the confidence intervals, is it applicable to the Asian population?
Great question. My assumption, that's all it's going to be, is an assumption, is the answer will be yes, because we're looking at change, not an actual value. We do know, and we've published this, that the normal values are different in different geographic populations. But the progression display is actually kind of what Renato mentioned. It's based on precision, not accuracy. So it's based on noise levels, not necessarily a specific number. So my assumption would be is while the bad display does need some adjustments for different geographic areas, the progression display is a noise measurement, and my assumption would be is that would be very similar throughout geographic areas. Great question, though.
Thank you, Professor Bellin. Then another one for you, Professor. Is there any of the parameters that carry more weight to make a decision when it comes to progression?
So I'll kind of reverse that and say my least comfortable parameter is corneal thickness. And And the reason for that is we know that corneal thickness will vary throughout the day. When you first wake up, your cornea is thicker, particularly if you have even mild endothelial dysfunction. But when we do noise measurements, they're repeated measurements really at the same time. So my least comfortable parameter is corneal thickness. In general, my guidelines are I like to see at least one parameter at the 95% confidence interval over 2 exams, or 2 parameters at the 80%. 2 parameters at 80 is effectively, from a statistical point of view, the same as 1 at 995. If you do 20% of 20%, it's 4%, so it's 96%. But again, my least comfortable parameter is corneal thickness. And if I only had a single parameter change in corneal thickness, I would probably watch that patient and repeat the exams a few times. And I think that's just normal because of the limitation of our reproducibility studies.
Thank you. Thank you. Is there any other questions? I'm not seeing anything coming in at the moment.
There was one question after Michael's first talk, not directly related to progression, but more diagnostics using tomography. I think a question which came up already many years before, difference between best fit toric ellipsoid and best fit sphere. What do you prefer, Michael, and why?
Okay, so I know this is this constant decade-long discussion. A reference surface is a reference surface. It has nothing to do with the accuracy of the display. And I always use the example, you can measure the height of a building from sea level, from the ground floor, from the basement. These are all accurate. They're all going to be different. What we compare the data to doesn't affect the accuracy of the data. It will affect the appearance. I use the best fit sphere because it gives us the most visually intuitive display. You can see the ectatic region the easiest, and actually that enhanced reference surface makes it even easier to see. You can use any reference surface you want, but then you have to generate all new normal values, and they will be different depending on the reference surface. They're also different depending on the optical zone you use. And I know some people use a 9mm optical zone. All of our published work is based on an 8.0mm optical zone. The reason I don't like a best fit toric ellipse is because it will fit the cone better, and that's not what we want to do. A conical cornea is a toric, and it'll fit better. But it's kind of like looking, if you put a red balloon in a room painted with red, it's harder to see. So I want to put that red balloon in a room painted white because it makes it much easier. So from a visual inspection, a best fit sphere is the easiest and most intuitive clinically.
Thank you. And then one last question is to Professor Ambrósio. Is SMILE your first choice for susceptible ectasia patients?
That's a good question. While I love SMILE, I love the first day of SMILE, I still have to acknowledge that PRK, surface ablation, has a lower impact on the corneal biomechanics than any lamellar procedure, including LASIK and SMILE. SMILE is in between PRK and LASIK, but surface ablation is the best procedure in terms of biomechanics. Eventually, the best procedure will be even a phakic IOL. So you have even to consider that, or eventually going inside the eye for lens replacement. But it's very important that we acknowledge that the SMILE is a great procedure, has a huge opportunity to improve dry eye and ocular biomechanics and predictability eventually. All these considerations does not lead SMILE to risk-free for ectasia, as that's the first and ever only ectasia that I had in my career. So I would believe that I really pushed the limits, and I learned tremendously how to even understand the problem and treat the problem in all senses, including patient counseling, patient doctor-patient relation. It's a huge process of involvement, and learning from the pre-op data with the TBI was just an extra plus in this interesting situation for treating this patient.
Thank you. And I said it was the last one, but to conclude the session, the very last one, as an eye allergy can cause ectasia and keratoconus, what should be the counseling for the patient with the eye allergy?
I would say that first, don't rub the eye. If you have the caruncula, which is easily rubbed, and you can relieve your eager to rub the eye, just rubbing the caruncula without pressuring the eyeball. Of course, treating the allergy, go to a doctor and have you can treat the allergy. You can go for allergy control, and today I'm using a lot vitamin B2 orally, which is a very much non-invasive way of enhancing the natural cross-linking. So don't rub the eye, treat the allergy, visit your doctor, do a pentacam and a follow-up with the ABCD. That's what you need to do for a very nice care for the patient.
Thank you. Thank you very much. And I think with that, our session has come to an end. We've passed the hour. I would like to once again thank you, Professor Bellin and Professor Ambrósio, for giving these talks today. And I would also like to thank you, our audience, for taking time out of your schedule to listen to us today. Furthermore, I would like to invite you to visit our online show in celebration of our 125th birthday. There's more info about the products and some other sessions. And with that, I hope you stay safe. Good evening, good afternoon, and enjoy your morning for those still in the morning. Bye-bye.
Thank you. Take care, everybody.
Take care.
Thank you,
Okay.
everybody.
Good to see you. Bye-bye.
Bye-bye.